Well, that's lovely. Thank you very much for joining us, Sam. That's really great. So now we're live on Facebook. So I'd like to welcome all our members who are popping in today, and I'll have a look and see who's there.
Wonderful.
And I'd really like to introduce Sam Cottrell and Tracy Patten, who've joined us from the nursing team at Bullen, who provide the service for Shine Health Direct. So good afternoon, both of you.
Hi,
Tracy and Sam are going to tell us a little bit about what they do, their experience, and they've got some tips and hints about managing particularly bladder issues, perhaps a little bit better, little hacks that you might not have thought of, or little bits of equipment that you might not realise is out there. But they're going to just tell us a bit about what they do, and we would like to be in the future working a little bit closer with them. There's so much experience in this team. I was absolutely awestruck when Sam told me about it, so I'm quite envious. And I think we just need to kind of find lots of ways to kind of tap into your experience. So would you like to start? Tell us about.
Yeah, of course I can start. So my name's Sam. I've been a nurse in the NHS and the private sector for quite a few years now. I won't say how many, but my background is predominantly colorectal. So I was initially working on the wards with patients just as they had their surgeries. Then I worked in ICU and high dependency, again, colorectal general surgery for about 6 or 7 years. I then went on to be a district nurse. So I was district nursing for a while. And then I came back to the hospital setting. I did miss that sort of environment, and I went straight back to high dependency ICU. And it was at that point I'd been helping out in the communities as a district nurse prior to this, and I'd gotten quite interested in specialising in stoma care. So I was a stoma care specialist in the hospital that I was based in. And then I was also a nurse practitioner in intestinal failure for about 3 years on top of that, which gave me quite a good overview into the problems that many people face, many of yourselves may face. And it was only from there I did my nurse prescribing, came out into the private sector, worked for Amcare for a few years under Convatec, and then came to Bullens. And now my role at Bullens is quite different. I'm now running an NHS commissioned service that provides a centralised prescribing service for all stoma patients. So it cuts the GP out, really. It doesn't change people's DACs or stoma nurses. It just cuts the GP out of the equation. And I do all the prescriptions for all those people, which means because I know what people need and I understand it a bit better, it's a process that we're hoping will standardise stoma care throughout the UK eventually. So that's a little bit about me and the service here. And Tracy will let you know a bit about what she does for Bullens as well.
Hi, I'm one of the clinical nurse advisors for Bullens Healthcare. There is currently 4 nurses doing the same kind of job as myself, whereby we support all our patients in community, working along you guys as well to support you. My speciality is more bladder and bowel, neurogenic bladder and bowel as well. So I can support patients with bladder problems, but in a nice way, so I can make it more comfortable for yourselves and suggest things that might help you daily. I also have a lot to do with bowel management and irrigation. Also the stoma side a little bit like Sam, but not with quite that much experience. But yeah, it's all about getting to know the individual, talking to you guys and seeing what we can do for you that might make your life a little bit easier. My background is the hospital, obviously, for a long time, community, as a district nurse. I've been a research nurse. I've been a nurse at GP surgery, which was quite interesting. But ultimately, I've always come back to what I love, which is bladder and bowel, which I picked up a lot of my knowledge from when I was working in the spinal world, based in London. So yeah, I feel I can give you guys a lot of support out there. Thank you, Jill.
Thanks very much, Tracy. There's a massive amount of experience. I mean, like you, I love bladder and bowels as well. Don't take the mickey, members, but everybody who knows me knows that bladder and bowels is something that I'm absolutely passionate about as well. And I think for our members, it's the massive quality of life issue. It's not only a massive health issue, if your bladder, if you've got urinary tract infections or kidney stones, but living with chronic overloaded bowel and chronic constipation, people don't feel very well with that. What do you find kind of like, how would you go about it if you kind of came up to with somebody with neuropathic everything, and what would your advice be to them?
Are you thinking from the bladder situation?
Either, really, the bladder or the bowel, how would you?
So, I've seen a few shy patients already, thankfully, in community, which I was happy to do for yourself, Jill. And one of my chappies, even though this can relate to male or female, if you're thinking about the bladder, there's a lot of baggage that we carry around when we have to have an indwelling catheter, i.e. your leg bags. So, I don't know if you're all aware, but you can actually omit the leg bags completely and just use this lovely little device called a catheter valve, which is like a little tap. So instead of having all your leg bags on in the wrong position sometimes and uncomfortable, you can actually attach the tap independently to the catheter. So you're not having any bags whatsoever on your body in the daytime, which, if you think about it, a lot of you guys have to transfer between equipment. So if you've not got a bag on your leg, this little catheter now can just sit inside your underwear out the way and nobody knows it's there. But because you've got the tap allowing your bladder to fill up naturally, you can just still empty your bladder the same way that I would, but without having to have the indignity of a leg bag on. So that is a good little device there. Another little solution I found in community for male or females is, if you're using intermittent catheters, which I'm sure some of your members are, Jill, because I've seen a few. If you think about the intermittent catheter, as lovely as they are, this is a male one, by the way, sorry girls. I do have a female one as well. Some of these actually come with a bag attached on the end. So if you're having to use intermittent catheters during the day, fine. But if you're out and about of your own environment and you've got nowhere to go, having the bag is good. But if you've got these ones that don't come with a bag attached now, what you could do is use one of your night bags. Take it with you. Every single night bag on the market that is single use has a small attachment to the leg bag. Every single universal bag that's a single-use night bag will fit onto any intermittent catheter, male or female. Some brands with the ends filled in won't. If it's an open-ended one, everything will fit on there. The beauty of using a night bag, if you need to, once you've dropped it on the floor, even though you can't see the urine draining into a leg bag connected on the catheter, because it's on the floor away from you, your wheelchair, you can actually physically see the urine coming out. And plus, if you're somewhere that's not very clean, you've not got to worry about the process of having to sit on a dirty toilet. You can actually keep the lid down and transfer if you do, and just put the night bag on there. Or obviously using the ones with the bag attached would be a good idea to swap onto those ones instead of your current ones, which are just independent ones. So that's what I found, and I have helped a lot of your patients that way too, because this has been an issue for them. Thank you.
No, that's really good. I hadn't actually thought that the intermittent catheters could attach to the night bags. So that's really good. Fiona's going back to the flip flow valve, and she said that if you have it closed, does the urine back up into your bladder? Does that cause any issues with that?
Sorry, Jill. So the beauty of this little tab is the fact that, unlike yourself, I've not got the catheter. So my bladder fills and empties roughly 3.5 to 4 hours as a normal. Once we introduce the catheter, that takes away all our natural function of filling the bladder. So the benefit of the flip tap is immense because you're now reverting back to a normal bladder with the usage of capacity and draining. But whatever rubbish is in your bladder, i.e. little bits of debris, instead of it coming out and blocking the catheter, because you've closed the tap and your bladder's filling up like a little tank, when you open it, you're now going to empty the full volume plus any rubbish that will automatically could block up your catheter over time. So it's really beneficial. And the other thing, you're actually training your bladder to work like a normal bladder would, which is going to be so much more beneficial for you. So there's the only risk I would say honestly is if you do have a lot of debris and it did by some small chance block the holes in the catheter while it was shut, but this would come down to the individual who's not properly hydrated enough, so they need more fluids. So again, it's a management thing. You can't just have a tap. You've got to be guided by a professional on how to use it and when. So, you know, there's lots of things to take into consideration. But if I see 10 patients with a catheter and I give 10 patients a tap, it pretty much works for 9 instantly. It's that efficient. It really is good.
Yeah. The I mean, some of our members, I think they're having an indwelling catheter. Sometimes it's because their bladders have been very, very overactive. Do you find that they're perhaps the people that they work less well in? Do you find that they?
Absolutely. Jill, my last lady, she was from Shine actually. She was only young. We tried it with her to omit the catheter and the bags because she was so young and active. But she couldn't cope. It was like literally every half an hour. So again, it's finding the suitable person, isn't it?
It is, yeah.
Don't be put off because if that was the one person out of 10, the other 9 it worked for.
Yeah, and I think that's that's a good result, isn't it? You know, that sometimes
that's massive,
yeah, that is massive. So I would imagine there would be some people who would be better off kind of like with some medication to relax their bladder down as well, or perhaps some Botox to relax it and allow that filling to happen. But it sounds like you get so much freedom from it if you have got an indwelling catheter. It sounds like you can get a lot of freedom from the bags.
Yeah, definitely. And like if there was an issue where in the night time you've got an eye output, you just attach your night bag on there every night and leave the tap open so you can still have a good night's sleep. It's only when you're getting really good signals that it's working that you could omit the night bag and think about using it 24/7. So, you know, there's lots of options we use there.
Yeah, no, that's really handy. And I think like indwelling catheters blocking, I mean, I think that's something that I know we've got some of our leading scientists kind of working on ways of stopping that. Probably not allowed to say too much about it, I think, really, otherwise they'll be after me. But you know, to actually develop material that doesn't have that the crystals are forming on it and the debris blocking it up. But is there anything else if people are finding that their catheters are blocking up on a regular basis, like Laura says hers does? You know, and you know, is there any particular tips that you would give?
Again, like for Laura, you're looking at bladder, you're looking at the management of that device. So a catheter, it's not just a tube that sits there and works. You've got to have it managed, which would be by your nursing professional or your other professional from the medical side, because if the catheter's in and you've got problems with it, it's not doing the job it's supposed to. So even putting the flip valve on, you're going to cut down the risk from the debris because you're keeping it diluted. Another thing you could be thinking about is catheter solution management, whereby a flush of like citric acid or saline is flushed through the catheter, which then cleans off the rubbish and allows it to flow. But that's something that needs to be performed by the district nurses a couple of times a week to have a good effect. following the RCN guidelines. And if the nurses are not giving that service to that patient, or it's not been flagged, then they might need to have a review of the catheter by that professional, so they can start putting that plan in action for them. Because sometimes the nurses will come out and only do the bladder washouts when the catheter's blocked, and it's too late then because we've not managed the catheter to stop it blocking. So yeah, I would speak to your nursing professional. And these patients, Shine or anyone, can actually be taught to use these devices themselves. You don't have to wait for the nurse to come in. You can be taught. It's quite easy.
Yeah, no, that's really helpful. Yeah, because I think especially with the pandemic going on, I think everything's been cut down to the bone, hasn't it? So the the more people can do for themselves to manage their health and their healthcare, really the better, isn't it? Really.
Oh, definitely.
But no, that's really helpful. I mean, I think there's some of our members who are perhaps in their middle years. I think we didn't have the advantage, I think, of the knowledge that we've got about how bladders work and how they can be supported now. I think it was quite I think when I started was in 1990, I think it was. Not with Shine, I was working with like catheterized people, and it was all fairly new. And it was my responsibility to go and sort of take the medications at lunchtime, and everybody had give me that look when I came around with the oxybutynin, and I said, what is it? And they said, this is horrible. It makes my mouth dry, it makes my sight blurry, it makes my skin hot, it's disgusting. So up to a point things haven't moved on an awful lot, have they really?
No, but yeah, it's not good.
So that's absolutely fabulous. Bowels, I think I get to talk to a lot of our members, I think, about their bowels, and sometimes people do feel like they've tried everything that there is, and they just say, oh, I want a colostomy, but sometimes it's a really good solution. But I think for some people as well, especially if their abdominal muscles are a bit affected, it's not always as straightforward. I think quite a lot of our members have said they have hernias, or it's collapsed. It can be fantastic. It can be very liberating, can't it, Sam? Or what would you say to people who are thinking?
Yeah, I mean, obviously, it's a big decision, because it does change everything about you and how you live. But then again, I've seen patients that are probably members of your group before I came to Bullens, and I've seen people pre-op and post-op in many different settings. It has to be a very personal decision. The thing is, predominantly the people that I've seen choose the route of having a colostomy. It takes away all of the issues around manual evacuation, a lack of control of your own bowels, which is just awful, having that lack of control. Lots of people opt for a colostomy, which is absolutely fine to do with support and the right counselling, which is something I do pre-op for many patients. I'll speak to them for as many hours as it takes to explain about how it will affect their lives, what will change, what won't change. Not only that there's not negatives, there's lots of positives. So with having a colostomy, it takes away the impersonal parts of your care that you might need having done by a carer or a family member, which I've seen. So having a colostomy, if you've still got use of your hands, or even some strength in one hand, or minor strength in both hands, and some partial dexterity, we can still get people to be independent with their own bowel care. Now, if that has been the major factor that most people have wanted, that, and it's to be independent. And of course, wherever, I'd always support that. So there's good fors and there's some against. It all is underpinned with good advice pre-op. I would never expect anyone to go into some decisions like that without having spoken to a stoma nurse first, of course. But if that is what you're ultimately looking for, a colostomy is often a very good choice. Although it might seem, well, it's this and I've got my pouches, but it does give you that independence back if it's possible. And also, because you've got your independence with your bowels and you can see in effect what's coming out, because that's how it works, you can therefore take over your diet a little bit better. You know what you should be eating, what works better for you, what doesn't work better. So it gives you a whole different aspect of independence and control over your own body. You can never control your output. That's not quite what I'm saying. But what it does do is it gives you ownership of what's going in and what's coming out sometimes. So I've seen twos and, you know, and against on many occasions, but I'll be honest, it's mostly positive. It's very rare I've seen someone in your members' types of positions that opt for a stoma and are not happy with the outcome.
I think that's absolutely, you know, absolutely great. And I think for a lot of people, kind of especially with a lot of physical impairments, it really can be so liberating, you know, that it's something that they can do themselves. You know, and I think when transanal irrigation started coming out, I think there was a survey done from spinal injury patients and those who had a colostomy, and they said, like, how long, you know, when would you like to have been offered this? And so many people said, you know, right at the beginning, those years of trying to find another solution to it kind of really felt like a bit of a waste. And I think it's just for those few people for whom it really doesn't go well, it collapses, it herniates, and, you know, all those other things. I can understand the caution, but I think you have to see, you know, you have to see people's life through the eyes of the person who's got the challenge, really, rather than your own eyes and things. But yeah, it has been one of those things that's really allowed some of our members to live on their own when everybody said, well, how are you going to do it? And skincare, not to mention skincare, if anybody's got any wounds kind of, you know, on their bottom or their sacrum and their bowels aren't, you know, in very good control, you know, that's almost, it's a recipe for a pressure sore, isn't it, really?
Oh, I was going to say, to be honest, Jill, that has been, I've been in lots of care homes and people's homes, personal homes, and seen real bad issues with piles from the constant, you know, the trauma that's caused by the irrigation or manual evacuation and the pain it causes. And then in that instance, I would always advocate for a colostomy, because then it takes away all of that. That's all ended. It heals, it settles. And in those instances where there's pain and it's so uncomfortable, and obviously it's such a personal procedure for that person, especially if somebody else is having to do it for them. As a nurse, I would always opt for independence wherever I can and ownership of your own health. It gives a more positive mental attitude as well towards what you're going through if you can control things a bit better. So I always, anything where I've seen that in those instances and where surgery is an option, it's something I've discussed with people many times.
No, that's excellent. I think sometimes as well, I think when people are thinking towards a colostomy and they've already got a urinary stoma, sometimes the surgeons are saying, well, we're not actually totally sure where we can put this, that you're going to be able to reach it comfortably, because you've already got where I would have put it, you've already got something there. So no, I think that's really helpful.
And obviously as a stoma nurse, whenever I cite people pre-op, so I go and put the marks on people's tummies before the surgeries, and I always put 2 marks on anyway. I can always find somewhere for a stoma to go. The surgeons might find it difficult, but I can usually find an area that it would work for that person, because that's the other thing, it has to work. There would be no point having it and it being in an awful position and then becoming an unmanageable stoma. So with the right support and informed education of the patient and understanding their anatomy, there's usually always an option. So it's quite common that I see people with 2 stomas. That's not unusual and one would be urinary stoma and one would be a fecal stoma. So that's not uncommon for me to see. But we've got 2 sides of the abdomen. Usually always can put them on one on either side.
Excellent. We've got quite a few of our adult members had ACE procedures done when they were a bit younger. And I think they're doing them a bit less now with young people now, because I think transanal irrigation like Peristeen and Cufora Iricida have sort of taken over from that and kind of ruled out the need for it. But then they're not without their challenges as well, are they really? What
no, they're not really. And I don't have much involvement anymore, really, not for many years with ACE procedures. We'd stopped doing them some years ago at the hospital that I was with. We used to see some children filter through, but there was always issues around the products and, you know, the replacement parts. And we actually stopped as a trust doing them some time ago. So that's not something I see very often anymore. I used to, initially we would see lots of issues with skin and leaks and just people struggling to manage them generally. So that was there was lots of audits around the actual procedure, and they was pretty much stopped in our area really, and we just never saw them really. They would sometimes go to more specialist places, but we didn't see them generally as a trust, which does tie in with what you say, that they're not doing them as much anymore.
They're not. And I think when I spoke to Mr. Malone, I think who developed it, just not long before he retired, and he said he was really pleased that he wasn't even doing them anymore, really, because of the transanal irrigation and the good results from that. But we still do have some of our members who have them and still use them, and they're still patent, but you know, they are a bit leaky. And I think especially if your weight goes up or down to any greater or lesser effect, because it's got to go through from the skin into your bowel, isn't it? And anything that changes in the way is going to and I say this to all patients, stoma patients. As you do age, we don't just age on the outside, we age on the inside as well. So it does, everything changes, which can cause problems then in later life. So again, linking that back to a general surgical stoma, stomas change over time. Just as we change on the outside, our bowels change on the inside. They go a little bit more floppier, a bit looser. And that's why you see little things as you get older, things changing, the size and shape of your stoma changes as well. But that's all quite normal because we're all aging. And I think that's an important part, because I think a lot of our members with spina bifida, as they do get into the middle years, not only are they going through the typical aging that we all do, especially me, but in terms of things like tethered cord, actually the effects of the spina bifida on their body going on for a long time as well. And some people, if they've experienced like chronic constipation and overloading, that's going to take its toll on how their bowels work. The menopause, all those things really do. So nothing really stays the same. And I think it's such a massive frustration for our members, because they get things just right, and then what they're doing every day just doesn't work anymore. It's like going back to the drawing board all the time at several points in your life. It's really annoying, but there's always something else to try, I think, isn't there? Laura wants to know if ACEs can be reversed and stomas done, and I would say there's no reason why not, if that's what you're thinking.
I agree with that. I have seen that before. As I've said, obviously the ACEs had stopped, not stopped, but lessened in many areas, but it isn't uncommon to have that done if you have a surgical consultation and it's viable and you're not fit for surgery is the main thing. If that's a potential, it's definitely worth exploring with your consultant, with your colorectal consultant.
No, I think that's a really useful thing. It's just keeping an eye on your independence and your life. And if you're not happy with how things are going, asking those questions, is there anything else that we can be done? But, they're quite big operations. You'd have to have a look at, things like people's general health and their lung expansion, and, whether an anaesthetic is a really good idea. But
Yeah.
I mean, certainly you can ask the question. If you don't ask in this day and age, if you don't ask, you don't get to find out, do you?
No, and I think the thing is with patients with any, if you're stable with your colorectal, you know, where you are at that time, if you're stable, you function, you manage your own care, if you don't ask, you won't be contacted. That's the thing. You've got to reach out for support. If things have changed for you, or you might want to try something different, then absolutely get a referral in via your GP, or if you've got your regular outpatients, bring it up. Make sure people are aware that you've got questions.
Yeah, definitely.
Yeah. Nina says she gets blood clots coming through her catheter. Why is that? That sounds like that should be checked out, to be honest, Nina.
Yeah, definitely. Yeah, I'd go and see a professional about that. That's not normal. That's not normal. It could be like infection, could be dehydration, but it could be the positioning of the catheter or the use of it. But there's lots of things can go wrong inside that little urethra. So I'd definitely go and get it sorted, just for peace of mind more than anything.
Yeah, and I think just as a quick word, while I've got, you know, so many members there who wanting to know more about their bladders and bowels, never take it for granted that whatever you're experiencing, whether it's pain or bleeding or extra infections or not being able to pass your catheter, don't ever just accept that that is just part of your condition, and don't let anybody fob you off. It should all be checked out. You know, all those you know, all those changes, you know, there is, as we've got on our website, you know, there is an increased risk of bladder cancer, unfortunately, for people with spina bifida. So never take those signs as, oh, it just is, and don't let anybody tell you, oh, it's spina bifida, what do you expect? Because it should always be checked out.
Yeah, definitely. It's your body, you know what's right and what's not right. And it's like when you get that gut feeling, go with it and get some support. It might not be nothing, but if it is, then, and like if you go somewhere and you don't get the advice you're looking for, or you're not convinced, you can always come and ask us. You know, we're here to give advice as well. We're happy to help. I have to say, a lot of my experience has taught me a lot in the last 4 years while I've been with Bullens, and that's not come from professionals, that's come from listening to my patients, because you tell me far more than anybody else has ever done, because you're living with these problems. And if somebody listens and actions things for you, you will get good answers and you'll get relief. It's so easy to do. I see it all the time.
Yeah, no, I think that's great. Fiona wants to know a bit more. She wants to sort of flag up that sometimes you get skin problems around stomas, and you know, what's kind of a good way of tackling that, really, because that can be a bit of a nuisance, can't it?
It can, yeah, and I think it's one of the number one problems that I come across. 9 times out of 10, it's one of the easiest things to fix, and it's usually, I say usually, starts with the template of your stoma pouch, so the cutting around your stoma. And I think, as we said before, people change over time. If you've not had a template check for many years, you can more than likely be guaranteed that the template of your stoma pouch is probably not the same shape your stoma was 5 years ago. And that's not uncommon, that's absolutely normal. It's nothing wrong, it's just that, as we said before, we change all the time on the inside and outside. You might have put weight on, you might have lost weight, you might have had surgery which changes the shape of your abdomen as well, so you might have some scarring going on. So it's usually very common for the template not to be quite right. If the template's not quite right and there is skin exposed to the output, whether it's urine or fecal, it will damage the skin. So lots of our patients, or lots of my patients, the people that I see, it can usually be fixed with a quick template check. If it's not a template check, so the template's perfect, but the skin still looks quite sore, it could be a little bit of skin stripping or a bit of being overzealous with your cleaning or cleansing. So if you're a bit rough with your skin and a bit rough with the stoma, not that you do too much damage, but it can cause abrasion. Then you stick in a pouch over the top of it again as well. Although the pouches are very good, lots of them, you know, are very rich in colloids which help promote healthy skin. If you're very rough with the skin, or you're pulling at your bags to get them off and maybe not using an adhesive remover, that can cause bits of skin stripping, so it just makes the skin quite pink almost. Other problems can be because you've had a change in shape of your tummy. So you may have a pouch that's a flat pouch, so it's completely flat when you look at your pouch side on, but your stoma could also be quite flat, and it could just leak bits of mucus under your flange, and that can cause sore skin. That can often be corrected with a convex pouch, so the back of the pouch will have a bump on it, and the convex pouches anchor the stoma just a little bit better into position, so they put a small amount of pressure around the stoma, which pops it a bit further into your pouch, that when it does function, because our bowels are always wet as well, our bowels are always wet. We wouldn't normally see them because they're on the insides of us, but when you have a stoma, part of your bowel is on the outside, and it's normal for it all to be wet. But what's in that mucus is enzymes and things to break food down, which also make the skin quite sore. So anything where you've got leaky, you know, like if your flange isn't quite fitting correctly, or you need a firmer convex pouch to anchor that stoma into place, those are the sorts of issues that often, more often than not, have caused sore skin. Also, if you have other issues, such as if you are, say, having chemotherapy, have a low immune system, you can have an increased chance of developing thrush. So you can get thrush under your pouch. You might think it's just sore skin. But I would usually, if I ever found someone with skin that was looking quite sore, a bit sticky, a bit wet, I would always swab it and send it off. I've had lots of people think it's sore skin for whatever reasons, and it's come back as thrush, which can easily be treated with a capsule, not a cream. There's no point putting creams under your pouches won't stick. But that's usually a common factor as well. So if you have lots of other things going on, you're not very well, you might have cancer, you might have cancer treatments, any sort of autoimmune disorders which lower your immunity, you have a higher increased chance of getting thrush. And like I say, that doesn't have to be under your armpits, it's anywhere where it's warm, so under your pouch is very warm. If you have problems with eczema or psoriasis, that can develop under your pouch as well and can be treated with steroids. So there's lots and lots of different reasons, but for any of your members of, I always say, I've heard some people say, well, sore skin is normal. It's not ever normal. You should never have sore skin. The skin should look here like it does under your pouch. There should be no difference to your skin. It should look the same all over. And the pouches are made and designed to promote healthy skin, to let your skin breathe, to let your skin have a good seal away from the output, and also obviously to give you the protection from the output. So the pouches do a really good job. And another study that I've been involved with was looking at how many aerosol type products we use on our skin. So like the barrier sprays, the adhesive removers, if you're using lots of wipes and wands and all sorts on your skin, that can cause problems as well. So the more chemicals you're putting on your skin, that can also increase your risk of soreness as well.
Yeah, no, that's excellent. And Fiona mentioned that some baby wipes, be careful of baby wipes, because some of them contain latex, which, you know, some of our, especially our older members, have got a latex allergy. And always check the ingredients of things that you're putting close to.
Yeah. And as a nurse, because obviously I am used to seeing patients pre-op and immediately post-op, as a stoma nurse, we never advocate using wipes around your stoma. We always just say use water straight as it comes from the tap on your dry wipes that you get from your delivery company or for wherever you source your products from, and just use water to clean. Nothing soapy, nothing too high in chemicals. Baby wipes are often high in lots of different chemicals, and the skin can become quite prone in those areas to damage if you're using them. If I say, for example, if I had an aerosol spray and I sprayed it on one piece of my skin every single day for however many years, I'm sure I'd have a red mark there. So it's about thinking about what you're putting on your skin as well. But as a nurse, we never advocate using wipes. We always advocate using just water, just as it comes straight out of the tap.
That's excellent. We've got quite a lot of comments of people saying how useful they're finding this. So that's really, that's really, really good. I knew they would. I knew they would. I think I kind of, when I'm talking to quite a lot of our adult members, and one of the options for sort of bowel management, which is often passed some of our older members by, is kind of the transanal irrigation systems. You know, people have really kind of struggled, and they're often really keen to kind of give these a go, but they're not always designed to kind of be that easy. I think it's probably anatomically we're not designed to kind of be able to put things into our own bottoms with that much ease, are we really? It's probably it's probably quite good that we are designed like that. But you know, it's, you know, are you introducing people to kind of transanal irrigation, or do you mention it to people as options?
Personally, I am a bit of a transanal queen, I have to say. Sorry. So my other baby, which I love, is the bowels, because obviously we all need to poop. And unless we're going down Sam's route, which is wonderful for some people, a lot of people rely on irrigation, or they've been neglected and have never even been suggested to start irrigation. So as a nurse, I'm really fortunate where I'm allowed to go and see patients from new who've never used it, but it's been suggested by the colorectal teams, or following the conversation I've had, I can see there is a major issue and something like that would help them. So I'll write to the consultant for them. And basically I go in, I discuss the whole of their lifestyle, diet, exercise, bowel habits, fluids, and then we kind of put a little plan together, look at the medication, taking quite a few different systems that are available on prescription, explain every single one to them, the benefits of it and how they'd use it, and then if they're happy, we can even formulate a routine of use, either training the nurses, the carers, the patient individually, and within a matter of literally weeks, you normally get a nice routine going. It's that easy, and it's just water, there's no medication. You still have a little bit going in, because obviously we've got to manage top and bottom. But I can honestly say, hand on heart, irrigation is just lovely, and it's so beneficial when it's given in the right situation with the right support. A lot of the time you'll go to see colorectal teams, I'll just say, there you go, see ya, and that's it. And you won't see anybody again for 10 years. And you know, it's like the catheter, everything's got to be managed to work properly. So with a little bit of support, you can make a massive difference for your life. It's so easy. There's a couple of options on the market. There's little cone version, which is silicone and lovely and soft. So you've got less chance of soreness to the rectum and pain. There's no pain. Another type is like a catheter, which is almost the size of a pen, a biro, and the balloon inflates. But again, easy insertion. They're all, you either have lubricating gel or they're self-lubricating once they're wet. A lot of systems now, compared to the old times where it was pretty much peristeen, I think, are either little bags, a tube, and a little handheld pump. Some with a balloon stay in place on their own, so you've got your hand free to manage a control panel. So, you know, you'd be surprised what you can achieve if you're given the right support, and they are out there and they do work.
And it is the support. I think, you know, when I've sometimes had people that said, oh, you know, I took the information into my GP and said, prescribe me this. And they won't, they're going to, oh, I've got to be assessed, I've got to be shown, because that support is crucial, isn't it? I mean, the GPs at the end of the day probably could write a prescription out, and you're going to go home and think, okay, well, what do I do now?
Which end?
Yeah.
It's not just getting that prescription because you've seen something on the internet.
Yeah.
You've got hereditary problems, i.e. piles, bleeding. You're not really going to find out about the true capacity of that until you start popping things in your bottom. So you have got to have everything checked, even if
everything's got to be checked.
Hemorrhoid bleed quite badly, so it's all got to be done properly.
Yeah, it has, you know, just to make sure that it's safe and effective. But, you know, again, everybody's different, so everybody's got their own little regimes and things that they find, you know, helpful you know, little tweaks and little hacks, how much water, how often you put it in on.
Yeah.
Something I've got to follow this up, but somebody said that they'd been given a toilet seat by some company that had made it specifically for them with, you know, like sometimes you get the toilet seat and you've got a gap at the front. This one had the gap at the side so that you could actually access your irrigation, or, you know, do your manual if that's what you wanted. So I really need to find out more about that, because you know, that's genius, really. Something so simple.
Again, sorry, Jill, it is good to do the procedure out of the toilet, but a lot of my patients can't access a toilet. So again, we look at ways of doing it on the bed or above the bed. So it's not all about, ideally it would be, but yeah, there are other ways around things. Yeah,
excellent. And as well, kind of being able to see people in their home environment and how do they do things. It's as important as what can you physically do. It's kind of like, what, you know, what do you need at home to be able to do this?
Yeah.
Laura's got a question about her sodium chloride suppliers have stopped bottles and now sending pouches that you have to put into the bottles. Is that to do your ACE, Laura? And is that okay? I mean, a lot of people with their ACEs, they would use tap water. They wouldn't be really just straight out of the tap, just lukewarm water. So they wouldn't really, I know some places started people off with, you know, salty water and saline, but your bowel is not a clean place particularly, and it doesn't need to. So if you need to put your sodium chloride into bottles so that you can actually do your ACE, then that would actually be fine. You know, it doesn't have to be sterile, because it's not going into a sterile place.
No.
But yeah, I mean, a lot of places started everybody off on tap water, and you know, that's just done everybody fine. So is there any more? Yeah, thanks, Laura, for the clarification. So yeah, and sometimes, yeah, Laura makes the point that sometimes actually having a family member that is trained in your care is kind of better than just having, you know, district nurses or something that will just come in and come out. You know, you can get, you know, what you want, you can get the consistency, you can get what you need when you need it. You know, if you're going out or something, and it just frees up the district nurses' time as well for other things. So it's a bit of a win-win. If you've got a family member that can and will do that, then that's great. Laura says, can she use tap water? Laura, if you've been told to use sodium chloride, I would raise that with the people that support you with your service, because I can't say it's okay to use tap water. All I'm saying is that's what a lot of people do use, and what a lot of people have been started on from the beginning of their ACE or their irrigation. But I can't actually say to you, you use tap water. But it's not going to cross-contaminate, because, you know, it's going into somewhere that's, you know, you haven't got anywhere in your body that's as dirty as in your bowel. You know, it's absolutely caked in bacteria. Most of them, you know, a lot of good bacteria, but bacteria nonetheless. So you're not going to do any harm. Sean says Guinness works great. I hope that's not for you. You know, I hope you're not doing your ACE with Guinness, Sean. Really, cut out the middleman, really. Yeah, so that's lovely. Just the mind, I've just got this picture in my mind now. I'm standing there kind of like just with the pint of Guinness going straight into there. Yeah,
waste of Guinness.
it sounds like it, you know, it sounds like it. Yeah, Laura says, yeah, use boiled water, let it cool with a quarter teaspoon of salt. If that's what works, yeah, I mean, it doesn't have to be surgical grade normal saline by any means at all, really. So, but whatever, you know, ask the service that provides you with that service for your ACE, and ask them if it's all right. It's probably more convenient to have, you know, tap water, I would think. You know, if you're going away on you know, going for trips away if we ever get let out of the country ever again, you know, like it'd be useful to know, you know, not to have to take shed loads of, you know, basically salty water with you, really. So Nina said in a catheter, the balloon, kind of sort of the water in it decreases without her deflating it. And does that happen to other people, and why?
Yeah, so literally once the balloon's inflated, it sits in your bladder, normally 10 mils, and it just sits on the neck of your sphincter muscle. It's just like a lock to keep it in place. If you suffer from spasms quite badly, the force will actually start to decrease the balloon by probably, I'd say a 10 mil. I've now come down to literally 6 mil, but that's been out for a few months, so it is quite normal. The only thing you might notice, was it Laura, sorry?
Yes.
Yeah, the only thing you might
Nina,
notice,
sorry, it's Nina.
Nina, sorry Nina. The only thing you might notice, love, is that you may start to get wet around the catheter like a pad, or if it's suprapubic, it clouds in, which means you might need to have it a new catheter inserted with a balloon reinflated to the full capacity, because if you're bypassing, you're putting yourself at risk of infections because the bacteria will get in. So it's okay if it comes down on a change, the nurses will notice the decrease in volume. But if it's happening regular and you're starting to be wet or a wet pad, you need that addressing with your nurses, love. And probably get it changed a bit more frequent before it decreases, or seek some medication to ease the spasms off for yourself.
To relax the bladder down a little bit, so you're not getting that pressure around it. Yeah. Oh, that sounds really good. A question from Laura a little bit earlier, sorry Laura, about barrier creams for, you know, sort of down below. What would do you recommend them, use them?
If you saw, like with the stomas and the skin was saying, we shouldn't be getting sore. So if it's from a catheter and it's bypassing and you're getting sore, the catheter needs addressing, as well as the sore skin, which would be medicated creams from your GP that you use the most tiniest amount and rub them in thoroughly. We don't want creams slapped on, because you're just going to make everything worse. It's trying to keep everything as dry as we can. So again, look at the catheter. If it's somebody with a catheter that's getting sore, because that's a definite now. If it's a pad they're using, an incontinent pad, and they're getting sore, that's now, because the volume on the pad might need increasing to cope with the output. So any issue with soreness to do with the bladder, get it reviewed by your GP or your nurse, because it needs addressing. It's not good, and a lot of creams will not help, and it's got to be the right cream.
Yeah.
And also the soap, you need something with like a natural pH to keep your skin balanced good, so you keep the good bugs. So yeah, go and speak to the GP and have it checked.
No, that's lovely. And I think like a lot of quite thick creams as well, if you are using a containment like a pad or something, you'll actually kind of waterproof the top of the pad, won't you?
Yeah.
And the urine won't actually be able to soak into, you know, to form the jelly as well. So it will just sit, and then it will just back up into your skin again.
Pads are very good,
more
but they're like tea bags, aren't they? So if we cover the tea bag up, it's not going to contain the volume that we want it to.
Yeah. Laura said, yeah, can her aunt, who's her carer, contact one of you if she needs advice?
Yeah,
Yeah.
Fabulous.
Anybody can. We're here.
Yeah. So just to let your members know, obviously there's 4 stoma nurses here, which we're all specialist stoma nurses. There's 4 of us, including myself, and then there's also 4 specialist urology nurses as well. So we have a system here at Bullens that you would phone in on the general number. If you want to speak to one of the nurses, one of the administrators outside here will forward those details on to myself and Tracy, and we give you a call. It's as straightforward as that.
That's absolutely fabulous. Absolutely fantastic. I think that's all our questions tied up, and that just leaves me to thank you both so much you know, I've learned loads, you know, it's been fantastic, and feedback from our members has just been really good. So thank you very much. So now you know Sam and Tracy and their colleagues and what they do and how you can access them. So fabulous. Thank you so much. Thank you.
Thank
Thank
you.
you.
Thanks everyone.
Bye everyone. Take care. Bye.